All right, great. We're going to get started. So hello, everyone, and welcome to the first of the MS Views and News MS NEURO TV series. We are so happy and excited that so many of you have decided to join in and are engaged and active in learning about living with MS. My name's Jennifer Falk, and I'm the Director of Development over at MS Views and News, and I'm here with Ana Cristina Fernandez de Castro, the Assistant Development Coordinator for MS Views and News. So tonight, we will begin by playing a 10-minute interview with Dr. Aaron Boster, who is a clinical neuroimmunologist who specializes in multiple sclerosis at Ohio Health. Once the video interview has finished, we will have Dr. Boster on the line for a 15-minute Q&A session followed by a brief survey. So let's get started with our MSTV Neuro video.
Welcome to MS NEURO TV, presented by MS Views and News. MS NEURO TV is a comprehensive educational program bringing together MS professionals from across the United States covering the topics that you want to learn more about. To register for MS NEURO TV webinars, visit www.msviewsandnews.org. Thank you. We hope you enjoy the program.
Dr. Boster, the question that so many have had since seeing this theory once or twice in the past, they've seen it, when we video recorded it a few years ago, they've heard about others speaking about it as well. Please tell us about, in very descriptive detail, about the leaky pool theory.
The topographical model of multiple sclerosis, or as I like to refer it, the leaky pool model of multiple sclerosis, was developed by a friend of mine, Krieger, who practices at Mount Sinai. I had no involvement in its development, but I am a student of this model and I fell in love with it. And I find it very, very useful in thinking about MS and understanding what causes MS, but also in communicating to patients and in tracking disease. And so it's with great pleasure I'll talk to you about the leaky pool. This is a model to help us understand MS. The first thing that we have to understand is we're talking about a swimming pool here, all right? And so the level of the water, we call that the clinical threshold. Everything above the level of the water, the human's aware of, like I can't see out of my eye, or my leg's numb, or my hand's clumsy. Everything below the water, the human's not aware of. Now, you'll see it on the MRI as a spot, but the human doesn't know about it. So that's the clinical threshold, the water surface level. The amount of water in the pool is called the functional capacity, or your functional reserve. Your functional reserve is really your nervous system's ability to withstand an insult. I don't mean you're ugly. I mean you didn't sleep last night, or you have an infection. Something that's challenging your nervous system. To make this clear, when I was 18, I could skip a night of sleep and not care. Now, in my mid-40s, just saying that to you makes me feel tired. My functional reserve isn't what it used to be. Now, different parts of the nervous system have different amounts of functional reserve. And so the leaky pool model has a shallow end and a deep end. The shallow end represents parts of the nervous system, like the optic nerves and spinal cord, that have very little functional reserve. The deep end, where there's a lot of functional reserve, represents the supratentorium, the lobes, and the top of the brain. Now, in Stephen's model, when there's activity, which means an attack or a new spot on MRI, it's depicted by a stalagmite, by a pillar that's pushed up from the floor of the swimming pool up into the water. And if that pillar crests the surface of the water, that's an attack. So if that occurs in the spinal cord, then in the model where the spinal cord is, where the shallow area, you would draw something coming up out of the water. If there's a spot on the MRI activity, but it's not manifested clinically, it won't crest the surface. The stalagmite will push up, but it'll stay under the water. And that's how you can represent areas where there's new MS activity. Now, it's called the leaky pool because slowly over time, the water starts to drain out of the pool. And if you imagine, this is one of those stalagmites, and this is the water level. And over the years, the water level drops, and it exposes that area. What's happening is old areas of damage are coming back out. They are wearing out, and you are now manifesting clinical symptoms where there used to be damage in the past. That's called progression. Another way of thinking about it, let's pretend that I had a shotgun and blew a couple holes in this wall, right? And we didn't patch the wall, we just left the holes in the wall. And then a couple years from now, there's an earthquake. That wall falls first because of the structural damage. Similarly, the areas where there's been activity, where those stalagmites occur, are exposed when the water level drops and you experience progression. The model's much more complicated than that, to be honest, but hopefully this gives you an initial understanding of its ability to help patients and other people understand the complexities of MS and why a spot today matters tomorrow. It's a very useful tool. I really love the leaky pool, and I want to say thank you to Stephen for developing it.
Thank you very much for answering this question. There's been a lot of research, and a lot of people are always asking what is being done these days to correct the myelin. And you know, some of the questions that have come up over the last few years, and a research study died out about it. We've heard that it died out, and is it being resurrected? Called anti-lingo. What can you tell us about anti-lingo?
So anti-lingo is a fascinating molecule. It's a monoclonal antibody, and it is one of our big hopes for a remyelinating agent. In the setting of multiple sclerosis, you have your wire, which is your nerve, and it's got a plastic coating on the outside. That's the myelin. And what the myelin does is it lets the nerve run really fast. When the immune system attacks that nerve, it strips away the plastic coating, it strips away the myelin and leaves the nerve exposed. It doesn't work very well. And so one of the things that we really feel we need is something to remyelinate, to put that myelin back. Now, we've seen with some of our highly effective therapies suggestions, but nothing at all conclusive that we're able to remyelinate. Anti-lingo looked early on like it might be able to do that. And as you alluded to, there was a clinical trial that did not meet its endpoint. It was a big, big devastation to our hearts. Fortunately, the manufacturer has gone back to the drawing board. They've revamped the trial. I'm excited that our center is participating in the upcoming trial, and we're going to go at it again with a slightly different model in hopes that we can, in fact, prove that it can remyelinate. Another area of remyelination, which I find absolutely fascinating, is this entire discussion of biotin. So biotin at 3 milligrams a day is awesome for your nails and hair. I probably should have used some years back. But we've learned now that super high dose biotin, I'm talking 300 milligrams a day, seems to have an effect in progression. There was an interesting poster that just came out at the international meeting at ECTRIMS, which would suggest that it can slow down progression. And there's a hypothesis that there may be remyelination involved in that, although I think that still needs to be borne out through future research. The solution to MS will not exist in only anti-inflammatory drugs. All of the 20 drugs we have right now are all anti-inflammatory, and that's important. But really, to lick this disease, we need three things. We need anti-inflammatories, which we currently have. We need a remyelinating agent, which we're working on, and we need something neuroprotective. If you think about the leaky pool model, we need a drug to stop the stalagmites from pushing up the new activity. We need a drug to refill the pool water, and we need something to plug the hole. We're still working on those last two.
Dr. Boster, thank you very much for answering this question. So many people are going to benefit from this response, so we look forward to, discussing more with you in the near future.
My pleasure.
Okay, that was great. So now we will open up the lines to you, to our audience, to type in your questions for Dr. Boster. Your questions will remain anonymous. As I see your questions coming in, I will then relay them to Dr. Boster. We'll try to get to as many questions as possible, and we'll try to address them in the order that they are received. You can type your questions in the GoToWebinar control panel that you can see on the right-hand side of your screen. You should see something that says question box and then type questions here. If you do not see this, please click on the small orange arrow that's at the right-hand side of your screen, and the question box should become available to you. So I'm going to turn this over to Dr. Boster. Welcome.
Thank you so much for having me. Good evening, and hello, everyone.
Awesome. Hello to you. And we have a lot of questions coming in for you. We're really happy that you're here and grateful that you can participate in today's webinar. Our first question is, I have 2 children. How likely are they to develop multiple sclerosis?
That's an excellent question, and I think it's one of the 2 most commonly asked questions when someone is first grappling with having a diagnosis of MS. So I really appreciate whoever asked it. I think that when we think about kids, we have to remember several things. First of all, multiple sclerosis is not a classic genetic condition. There are conditions out there like sickle cell anemia or cystic fibrosis, where if you have the condition, a certain percentage of your kids will have this, you know, a half or a quarter. In the multiple sclerosis, it doesn't work like that. If you have MS, your first degree relatives, which means brother, sister, mom, dad, kids, first degree relatives, have a risk that's between 1 and 3%. 1 and 3%, which is a very low percentage. Now, it's important to keep in mind that we think there are certain things that one can do that would probably change that risk, either increase it or decrease it. And so there's some science that supports the idea that children that are morbidly obese, really overweight, actually have a very significantly higher risk of developing MS compared to kids that are in their proper weight. And so that's one of the things that we talk about, that if your child is overweight, we might want to address that as it relates to decreasing the risk for MS potentially. Another really key learning is that exposure to smoke, tobacco smoke, either because a child's smoking, we would hope not, but maybe even secondhand smoke, increases the risk to develop MS. And so we don't want our children smoking. None of us want our children smoking, but people that have MS have an additional reason not to want them to do that. The third thing is very germane in my home state of Ohio, where there's not a lot of sun in the winter, and that's vitamin D levels. It appears that low levels of vitamin D increase an individual's risk to develop MS. And there's some evidence to suggest that we might be able to by raising the level, decrease that risk. And so when I'm talking to a family and we're identifying that mom has MS or dad has MS, I remind them that the risk of having MS to their children is very low, 1 to 3%, and that doing things like talking with the pediatrician about supplementing vitamin D, making sure that they avoid tobacco smoke and stay physically fit can all lower that risk. I think those are key elements to go over. Thank you for asking that question.
Okay, great. That's a great response. Thank you. And we have a lot of questions coming in about biotin. And some of them, the questions are, should I take over-the-counter biotin? And do you prescribe or suggest biotin to patients?
Absolutely. A very hot topic, biotin. So biotin is a vitamin. And if you go to your local health food store, you can find biotin where they sell it typically in 3 milligram pills or capsules. And that's a recommended daily suggestion, which is oftentimes used to enhance hair and nails, which is not why we're recommending it. Now, there's been some recent research done, which has really been rather compelling, 2 studies that I'm specifically speaking of. And these are studies looking at primary progressive multiple sclerosis patients. So these are people that until the advent of the most recent monoclonal didn't really have evidence of response to DMTs, right? So when you would apply them, they didn't slow the disease down. And what they found that high doses of biotin, and I'm talking really high, 300 milligrams a day, not 3, but 300, it seemed to slow disability progression. And in a separate study, it slowed brain shrinkage, or the rate of brain shrinkage or brain atrophy. Now that's really remarkable. And I'll make a couple of comments. Number one, it's not proven yet. There's 2 really remarkable studies, but I think there needs to be confirmatory studies done before we can adopt this as gospel. So I still want to state that this is something kind of early. That's the first thing. The second thing is I can't give a recommendation over a teleconference. I mean, that would be like not such a good idea. And I implore you, you got to talk to your provider about this. The third thing is I'm really excited about it. I'm talking to a lot of my patients about it, and together we're deciding to start it often, this biotin 300 milligrams. And the fourth thing, and this is very important, is that people who are taking high-dose biotin have a small risk that when they have laboratories done, the laboratories might be abnormal. There isn't a problem with the human body, but the numbers on the test come back weird. So for example, if you're on high-dose biotin and you have a thyroid test, there's a chance that it'll come back spurious. The number will be inappropriate. And that can also happen with a test to look at like heart function, like troponins. So that's very important to know that. And as it relates to things like thyroid, people that choose to take high-dose biotin, it's typically recommended that we stop it about a week before we have our testing so that that doesn't interfere. So in a nutshell, there's some early, really compelling research. One study on PPMS looking at disability progression on exam, another separate study looking at slowing rates of atrophy of the brain. Very exciting. This is a vitamin, and we're looking at doses that are 100 times higher than the recommended daily allowance. And whereas it appears to be a safe vitamin, we do have to keep in mind that it can change the results of certain laboratories and give us spurious results. So that's a little primer on biotin.
Thank you, Dr. Boster. I have our next question from Nanette. If you get sick or get an infection, can this cause new brain lesions? Also, can stress, good and bad stress, cause more brain lesions?
Excellent question. So let's take them in order. So the first one has to do with infection. And people get infected, right? So people get urinary tract infections, they get upper respiratory tract infections. You know, 'tis the season here in Ohio during the winter that we see a lot of this. We see a lot of bronchitis, we see a lot of pneumonia. And the question is if you have that, can it trigger an attack? So it's complicated. The answer is yes, it can. And there are times where we feel like the immune response to an infection is kind of revved up or inappropriate in the setting of MS, and it might trigger an attack. So that's a possibility. There's also another option which we can see clinically, which is called a pseudo attack. Pseudo is Greek for kind of like, but not really. So a pseudo attack is like an attack, but it's different, and I'll explain. When you have, I'll use the spinal cord as an example, damage to your spinal cord and it heals. You regain function of your spinal cord so your leg's not numb anymore. But if you looked at the spinal cord itself, it's still beat up. It still has a lesion there, right? And so even though you no longer have clinical symptoms, there's still a problem structurally with the spinal cord. And the way I like to think about that is to think about the spinal cord as like an electrical wire. And if the electrical wire is frayed, it still works, but it doesn't work as well as it used to. Now, in the electrical wire example, if you plug in too many things to it, it'll short circuit. In the spinal cord human example, if you overload the spinal cord, it can stop working. And a perfect example is an infection. So someone had a transverse myelitis back in the day, and they recovered from it clinically. They're doing better now. They're no longer numb, let's say, in their leg. And then they get let's say they get an upper respiratory tract infection, you know, in January in Ohio. And in the setting of that infection, they kind of overload, their body heats up and it short circuits their spinal cord and they get numb again. So the reason I'm bringing this up to you is the way that a human being presents to clinic isn't with, I have an infection. It's, I have a symptom. A lot of times someone comes in and say, hey, I'm having these symptoms and we're looking for infection. And we have to try to see, are they infected? Or someone has a cold and then they have new neuro symptoms. And in both situations, it's not straightforward. We have to do some investigations. We have to check and look for infection, and then if we find it, we have to treat it. So to speak in plain language, an infection can trigger an attack or cause new MS activity, but it can also worsen old activity, which can come out. And clinically, the way that manifests in a human being is hard to tell. And so it really takes coming into the clinic, being evaluated, and then having some lab testing for us to sort it out. The second question had to do with stress. And this is a largely unanswered question. And I think what you'll find is that different people have different opinions. And so I can share with you my opinion. My opinion is that psychosocial stressors can worsen MS symptoms. And I feel really strongly about that. You show me someone going through divorce, and I'll show you someone that has an uptick of their MS symptoms, right? Now, whether or not it can trigger an attack, I don't know the answer to that. I think there's been times that I've seen patients under significant psychosocial stressors, and they have an attack, and I can't come up with another trigger. But it's really an unanswered question, and I don't think that we have a good, solid scientific answer. So what I'm sharing with you is simply my opinion.
Okay, great. Thank you. Our next question is, I have seen on MS blogs that as you age, you may experience fewer relapses. I've even heard that one may stop experiencing relapses entirely after the age of 60 and may stop taking disease-modifying drugs. Is there any truth to this?
So let's pick apart what you're talking about. This is an excellent question. I thank you for posing it. So let's talk about things that we know to be true. Number one, disease activity, meaning attacks and new spots on MRI, are a function of chronologic age. So people who are in their 60s are statistically less likely to have attacks compared to people in their 30s. And they're less likely to have new spots on MRI compared to people in their 30s. So that's a true statement. But I also want to point out a second true statement. People in their 60s generally do not bounce back from their attacks as well as people in their 30s. So even though the proverbial 60-year-old has a lower risk of having attacks, if they have an attack, they typically don't fare as well as they would have if they were younger. There's a discussion being had amongst MS physicians currently internationally. And it's a discussion about, could we stop treating at some age? Now, I feel passionately that we should not. And I'm going to share with you why I feel that way. But I will tell you that this is an ongoing and very heated discussion. And there's even research investigations that are kicking off trying to look into this exact question. So here's the deal. When you take an MS therapeutic, you're buying an insurance policy against a future event. It's like taking a birth control pill against an attack. And as long as you're on that birth control pill, you are protected to some degree against that attack. If you are less likely to have an attack at age 60, that's great. But if you have one, you typically don't bounce back very well. So in my opinion, the insurance policy is worth it. You know, I typically use an example of wearing your seatbelt. So when you turn 60, do you stop wearing your seatbelt? Because, well, hell, you know, the first 60 years were fine. So, you know, I don't do as much driving in my 60s and I don't go as fast, so I'm just not going to put my seatbelt on. Absolutely not. Most 60-year-olds I know, they buckle up, right? And they buckle up because they don't know if they're going to get into an accident. And even if those things I said were true, they really do drive less and they don't drive as fast, that's good. But they still take the extra effort to secure themselves and protect themselves. And I think that people with MS as they age deserve to do that as well. The second point that I want to make about disease-modifying therapies is, in my opinion, it's not only about decreasing attacks. In fact, that's only one portion of some really important stuff that disease-modifying therapies do. Disease-modifying therapies have been shown to slow the accumulation of disability. And it's not just because they stop attacks. There's been studies done where they looked at people who had progressed in their MS to the point they needed a cane, and they weren't having attacks. In this one particular study, they stopped half of the drugs, or they stopped, half the people stopped their drugs, and half didn't. They stayed on drugs. And what they found was there were no attacks seen, but the people that came off drug got worse faster. You look at brain volumes, and we know that people with MS have a risk to have accelerated brain loss. Their brain shrinks faster than it's supposed to. These drugs, many of them have been shown to slow the loss of brain volume. It slows the rates of brain atrophy. So when you're taking a DMT, you're buying an insurance policy against an attack, yes. And you're buying an insurance policy against new spots, yes. But there's more going on than that. And I think that it's naive to stop something like that. You know, I have high cholesterol. Thanks a lot, Dad. And I take a statin every morning. You know, and if I said, well, how long should I take the statin? Should I stop when I'm 60? You would say no. And there's reasons for that. And so that's my passionate opinion about that question. This is, as I mentioned, ongoing and being studied and researched. And so I would look forward to upcoming congresses as we start to delve into this and try to answer the question with science. Thank you for asking it.
Thank you, Dr. Boster. That's an awesome response. We're going to move on to our final question for this evening. The question is, how is PPMS and RRMS, relapsing remitting MS, different at the cellular level, and why can't they be treated the same way?
Got it. So first of all, I have to share that I'm a clinical neuroimmunologist. I'm a doctor who takes care of humans for a living. And I'm very involved in clinical trials research, but I do not do research in the laboratory. So I just want to put it out there that I'm a clinic guy and not a basic scientist. And I can't speak to the cellular level differences between primary progressive MS and relapsing remitting MS. But I can talk about some of the differences that we see in between the two different phenotypes. So one of the things that we've noticed is that people with PPMS tend to have more spots in their spinal cord than in RRMS, and tend to have less spots in their brain than in RMS. That's an observation that we've made. We've observed that clinically, people with PPMS tend to accrue disability slightly faster than people with RMS. And there's some other things that we've noticed, but really what I would rather talk to you about is the fact that I think PPMS and RMS don't make much sense. So I'm gonna answer the question a little differently. These concepts of RRMS and PPMS are descriptions, they're phenotypes, they're outward descriptions. It's like a stereotype. So really, when you say RRMS or PPMS, it reminds me of some off-color guy saying, hey, look at that, quote, buxom blonde, end quote. Excuse me for saying that. When you call someone a buxom blonde, you know nothing about that person, or you're conveying nothing about that person except two features. You don't know what kind of music they like. You don't know their philosophy on life. You don't really know anything about them except these two features. And that could do a grave injustice to that human being. When I say RRMS, it's about as descriptive as buxom blonde. It doesn't tell me much about the patient, because people with relapsing MS can have progression. And people with progressive MS, including primary progressive MS, can have attacks. Yes, they can. And so I think as we have now adopted the 2013 revised phenotypes in MS, this is work by a very great man named Dr. Lublin and his colleagues, we have started, in my opinion, to shy away from those dogmatic terms. And we're now using beautiful descriptors when we talk about people. So when we talk about someone with relapsing MS or with progressive MS, we now talk about, so let me say that someone has so-called relapsing MS. I would say they have relapsing multiple sclerosis without activity, meaning no new spots or no attacks, without worsening, meaning their exam's not different, and without progression, meaning they haven't gotten worse in the absence of attacks. Those are some definitions. And you can apply the same terminology to someone with PPMS. So I have most certainly done your question an injustice, and that I have not talked about the cellular differences between RMS and PPMS. And in fact, I've kind of turned your question on its head a bit, forgive me, because I think that we do a better job describing MS with more terms than just those. I don't think they do an adequate justice to what's going on in the disease. My final comment is that in the future, we'll completely do away with RMS and PPMS, completely. And instead, we will describe the disease based on genetic and immunologic terms, which we're not there yet, but that's coming. There will be a day when we say, this is a B cell driven form of MS. This is a Th17 cell driven form of MS. And that's where the future is, but we're not there yet. Thank you for that question.
Thank you, Dr. Boster, and we all just want to thank you for providing us with these tremendous answers and unbelievable insight and teaching us in a way that not many can. So we really want to say thank you for being on the line tonight. Thank you, Dr. Boster.
It's my pleasure, and thank you very much for having me. I want to thank everyone who listened in for taking time out of their evenings to learn about something and to be part of a community fighting back against this nasty disease. Thank you all. Have a great night.
Awesome, thank you. And now I'd like to pass this to Anna Christina, who will give you some final information. Thank you.
Thank you, Jennifer and Dr. Boster, and thank you, our audience, for joining us and being a part of the first webinar of our monthly MS Neuro TV series. Our webinar series will be held every first Tuesday of the month, so keep an eye out for our next invitation. At the end of this webinar, we would like you to please complete a brief survey. We really value your feedback so we can incorporate your ideas into our events and address the topics that are most important to you. Your feedback will remain anonymous. We'd also like to thank Sanofi-Genzyme and Biotin for their support in making programs like this possible. If you missed the beginning of today's webinar, or if you'd like to watch it again, a recording will be made available on our MS Views and News YouTube Learning channel. So please don't forget to subscribe to stay updated. You can also follow us on Facebook, Instagram, and Twitter. For more information, please visit us at www.msvn.org. Thanks again so much for joining us. Take care.